Hello, good everyone. Good morning, everybody. This is Kelly Sandaker, your SURSAC administrator this morning. Glad to be here. I'm going to start off the meeting with just letting everybody know this meeting is being recorded. I'll be reading the disclaimer and comment guidelines and such, and then I'll be doing roll call this morning. Disclaimer: this meeting is being recorded and live streamed on TVW. This meeting recording will be shared on the HCA website on a page dedicated to SURSAC meeting information. The meeting recording is open to public disclosure. Please do not disclose any private or confidential information. Guidelines for public feedback. There will be 10 minutes at the beginning of the meeting and 10 more minutes near the end of the meeting reserved for public comment. Each person will have 3 minutes to provide feedback. If you're not a committee member and would like to make a comment during a particular discussion, please raise your hand for facilitator awareness, and public comment on that topic will be invited before moving to the next item. Feedback that is not provided during the meeting can be submitted via email at any time to hcaesb5476@hca.wa.gov. Well, Amber leaders. Senator Megan Dungria, Monka Dingra. Senator John Braun. Representative Lauren Davis. Representative Dan Griffey. Caleb Bantagreen.
Happy Monday.
Thank you. Don Julian Saucer.
Good morning.
Morning. John Meyer. Alexi Orr.
Good morning.
Amber Cope.
I'm here.
Brandy Flood. Stormy Howe.
Morning.
Chad Enright.
Good morning.
Morning. John Hayden.
Good morning.
Nikki Lewis. Jerry Candelero.
Good morning.
James Tillett.
Good morning.
Christina Lynch.
Good morning.
Sarah Gillard.
Good morning.
Donald Tanskley. No. Malika Lamont.
Present.
Addie Atwell.
Present. Good morning.
Kevin Ballard.
Good morning.
Hunter McKim.
Present. Good morning.
Representative Jamila Taylor. Representative Gina Mossbrocker. Okay, good morning, everybody. Glad you're here this morning. I would like to pass off to Tisha for HCA announcements this morning.
Hey, good morning, everyone. Can you guys hear me okay?
Yep.
Great. Well, good morning. For any of you that I haven't had the opportunity to meet yet, I'm Tisha Kirschbaum. I am the director at the Division of Behavioral Health and Recovery here at the Healthcare Authority. And I asked to get put on the agenda today because since Michael Langer retired back in July, Tony Walton has really been stepping in and providing a lot of support to the SURSAC group. And Sue Birch, our director here at the Healthcare Authority, has made the decision to officially appoint Tony in that role as representing the Healthcare Authority. So I just wanted to come and make that announcement. I wanted to say hello, introduce myself to any of you I haven't had the opportunity to meet yet, and also just thank Tony for his ongoing work to supporting SURSAC. Tony, do you have anything that you'd like to say?
No, just really appreciate the opportunity to kind of be interim chair for the past 3 months. And, I've been involved with SURSAC since day one, since the legislation passed in 5476, and just, really honored and just hope that I can continue to help support the good work that's happened and continues to happen, and participate in these meetings in a way that just starts to continue to move us towards better integration of behavioral health and intersection with the criminal legal system, and supporting a lot of the programs that came after the State versus Blake decision. And so just really appreciate Director Birch and Tisha, your support in doing that, as well as others at the Healthcare Authority. And other than that, no, just excited to continue to move forward.
Thank you, Tony. All right,
Thank
Kelly,
you.
back over to you.
Thank you so much, Tisha. I'd like to go ahead and pass it off to Blake Ellison now.
All right. Good morning, folks. It is time for public comment. Please, if you are a member of the public and would like to make a comment, please go ahead and raise your hand virtually, and we will call on you for comment. Again, time for public comment. If any member of the public would like to make a comment, now is the time. All right, last call for public comment. All right, we have no comments then today, this morning anyway. Does anybody have any walk-on item requests? Anybody want to add anything to the meeting this morning? If we have time, please raise your hand if you do. All right, thank you. So the first agenda item that we have is overdose data from 2023, and we're going to go over that with Tim. Before we do that, Tony, have any comments on this subject coming up?
No, just really appreciate Tim being here and helping share some of the most recent data. I mean, obviously, this is just one metric we have to help understand the way that substance use and substance use disorder is impacting our communities. And so just, I think this was a carryover from a request or a conversation we had in a previous month, and just wanting to kind of situate ourselves within kind of some of those the data that come out of Department of Health. So, nope, thank you.
All right, thank you. Take it away, Tim.
Cool. Thanks, Tony. So as Tony said, this is really a follow-up to some comments made a couple months back. Really curious to see what overdose data looks like in Washington State. Unfortunately, our epidemiologist who collects and synthesizes the data within our injury and violence prevention section within DOH was not able to attend today, but he did provide me a table with some brief talking points, but really this is more just a conversation. So I will share some of the updated data regarding overdose deaths in Washington State. It will just be looking at all drugs. It has not been broken down into drug categories such as synthetic opioids, stimulants, etc. And really, I think it's an opportunity for conversation as well. I'm sure many folks have seen the headlines that have been local and national around, anywhere from 10 to 20% reduction in overdose death rates. I know King County made that announcement that they've seen that reduction. NPR did a national piece on that as well. But I will say from the data, it looks like it might be too early to say that for Washington State as a whole. But we really wanted to just give some time to look at what these numbers are and what has been working, what hasn't been working, and just really open up dialogues. I know there's been a lot of thoughts around this topic. So I'm going to go ahead and share my screen. And take me 1 second.
And I'm not sure why the owl isn't working, but Tim is here. It's focused on me and Kelly, but Tim's right over here doing a great job. So
thanks, Tony. I even put a button up on today, so overachieving. Can folks see my screen?
Yeah.
Okay, perfect. So this is, as I said, are all drugs, and this is going back all the way to 2017. What I will say is that according to our epidemiologist, the 2023 numbers are complete. The 2024 numbers that you see are not complete, and they will change. We cannot make any assumptions based upon these numbers. The thought is that the numbers are plateauing, but to be able to drill down and say that there's anywhere from a 10 to 20% decrease is something that we cannot say at this time because these numbers will change. But as you saw, numbers have continuously rose since 2017. We crossed 3,000 deaths within 2023. And so currently with the numbers that we do have, which will change, we're sitting at 1,746. I'm going to go ahead and share another slide just to give another perspective because visuals matter. This increase has continued to go, but as you can see, the 3-month average looks like it's plateauing a little bit. You do see that dip right there in 2023, but then a modest rise. So fingers crossed that, in the state, we see trends across that have been seen across the country. But again, the 2024 numbers are still too early to make any assumptions based upon that. So I apologize that this wasn't broken down by drug type. But this is where we stand, and really we wanted to share this with folks based upon previous request of what the numbers look like statewide, and then in the last few months, the media releases from King County and nationally about the reduction. So I don't know if folks have comments, questions, things they would like to reflect back onto the group. Like I said, what's working, what's not working, what else do we need to do? Because while some jurisdictions have seen a decrease, I think it's important to understand, especially from looking at these numbers, that we have a long way to go. Even a 10 to 15% decrease, we're still looking at historic death numbers in regards to overdose. So with that, I kind of want to open it back up to the group, see if anybody has any questions, comments, etc. That's it.
Any questions for Tim?
Hi, everybody. Everett Maroon, how are you all today? Blue Mountain Heart to Heart in Walla Walla. Tim, are you talking about the ODs that are seen by, are you talking about fatalities and what the coroner data look like? You're not talking about like what any of the prevention of drug overdose self-reported use of naloxone data are, right?
Correct. The data that was reported is information for fatal overdoses that are reported via the local health jurisdictions.
Got it. Okay. Thank you.
So Everett, just to follow up, because I noticed your comment in the chat that OD events look pretty terrible out in the southeast catchment. And so I think that's an important distinction for those that are kind of attending, and clarification that, obviously to Tim's point and yours, this isn't capturing all these situations where an individual has overdosed and then either been resuscitated or administered naloxone. But it sounds like those events, the event of an overdose that doesn't result in a death, those are still increasing, or at least high frequency in your area.
Yes, I would say that we're seeing our highest ever reports of utilization of naloxone to deal with overdose events in our area. So between our Clarkston, Kennewick, and Walla Walla syringe service sites, our participants responded to 381 overdose events in October. And I think that there were 8 unsuccessful events responded to. So, we've never seen a number like that. We're up to, I think, 1,370 something on the year. And last year, with our PDO program, we had 933. So we have been on a year-over-year increase since COVID, basically since 2021. I just, everybody here knows that like every kind of OD figure you can get is an undercount. It's not fully representative of what's happening. So I just wish, I wish we had better data, but I know the nature of this is hard to track. But I just think, coroner data, Tim knows this, just takes so long to get them finalized. But what we're actually seeing on the ground out here is a really unheard of activity for us. There was one week in Benton County where the coroner said he had 19 fatalities in 1 week. And for a county of 200,000 people, that's pretty outstanding. So Walla Walla County is somewhere on a 2 times or 3 times of an increase in what they saw in September. So in their emergency department of their one hospital, where we would normally see 8 overdose arrivals at the ED, they saw 26. So that's just, there's something going on out here, and I don't think it's that we suddenly started doing a better job in September and October of getting naloxone to people. Although that's always a possibility.
Yeah, I mean, I think it's tough to draw that direct correlation, but it does definitely at least seem like the increase in fluctuation of naloxone distribution. I mean, you mentioned WAPDO, that's one of our statewide grants through SAMHSA, the Substance Abuse Mental Health Services Administration, and I know Department of Health has been helping support that, and also other naloxone distribution efforts. And so maybe that, I don't know if it's of interest to SURSAC and others, but that might be something we could kind of present on at a future date, is just kind of like a summary of Washington State's naloxone distribution efforts, at least like through like state proviso funding or our federal grants.
Yeah, I think it'd be great to talk about that. We've been involved in that effort since it started, and have been doing very diligent data collection. So Caleb, you should feel good about that. But I don't know what to say about, like, there's no we just collect the data and try to figure out ways to respond to it locally, but I'd love to see something that was turning that PDO effort into, I don't know, some sort of pipeline for a decision process for the state more generally. Like if something seems to be percolating in one area of the state, are there certain things that we could do in response, even in the short term? I'm shutting up now.
No, that's really helpful. And Emily Irio from Department of Health also provided, just directing everyone's attention to the chat, some additional context. Oh,
All right. Malika had her hand up. Malika, go ahead.
I agree with Everett, and I feel like there should be a bigger conversation that includes all the folks across the state. That I mean, these numbers are like I'm just sitting here kind of like I'm just sad. Like I feel like I want to cry. And I think that there needs to be a coordinated, broader conversation about maybe what all the places that are doing drug checking and I know that's your area, Caleb, so I'm suggesting what you should do with that, but it just seems to me that it would make sense to really get into what folks are seeing on the ground, and ways to make more inroads. Because even if we do end up, at the end of the year seeing that we had a dip or something like that, I'm sure the disparities are going to still be the same. And, we need to be doing more to address that as well. And collective thought tends to work better towards those things than just people shooting in the dark by themselves.
Thank you. Anything else for Tim? You see Caleb put a couple links in the chat as well. Thank you. Anything else on the subject of overdose data?
just thinking about Malika's comments, just wanted to flag that in December, we're trying to put together a kind of collaborative activity with the SURSAC members where we'll start to kind of identify the priorities for 2025 and 2026. I think it's similar to what we did last December and January. It's called a mural board, and it's kind of like this like virtual whiteboard where you can kind of put little posties where you want them and stuff. Really cool, and I think it's really helpful. And Caleb, didn't see your hand up. Sorry if I jumped. But just thinking I think this is a great conversation to be having now while prior to the December meeting when we really start to strategize about how to spend the next 12 months of 2025 and in what areas to focus on. So just really appreciate those comments.
Go ahead, Caleb.
Sure. I'll just note that the drug market's really, really, really messy, and things are happening faster than they ever have in terms of changes. We have some of the drug checking data there. We're working on a report right now sort of about the real changes we're seeing in the fentanyl market. And by fentanyl, I mean that kind of in quotes, where it really was primarily still fentanyl about a year ago, and it's much messier now in terms of other types of fentanyl products and other products, and sometimes no fentanyl in there. And we just don't know what the impacts are. We don't know. In some instances, it might actually lower overdose risk because it's less net opioid. In other instances, it might be carfentanil and dramatically increase overdose risk. So I'm just noting that it's really messy and really dynamic. We're going to be getting out data at least on a quarterly basis about the drug supply, and as emergent things come up more frequently than that. I'll put something in there around BTMPS, which is a newer product that we're seeing, and we're working on a brief right now that Everett really helped catalyze around carfentanil, which we're starting to see a little bit in the drug supply and sometimes more than a little bit in some places. But it's very hard to get a good picture on what's happening in the drug market in real time. We're definitely doing our best in terms of what we are able to access, which is monthly crime lab data, which are sitting on our webpage. Also, these drug checking data. The mortality data often take many, many months, if not from the state, 9 to 12 months to get. That's why the King County data are so valuable. So I'm just noting that it's a really messy time out there. It's a really scary time for folks. And there's also, we're deploying new and great interventions in better ways than we ever have, certainly in terms of access to medications. And we're also under real threat in many counties where they're trying to get rid of all harm reduction programs, which is also would obviously take us further back into the dark ages in terms of health and public health. So I'm just putting a bunch of stuff out there just to note it's a messy time and it's a hard time, and we'll do our best to try to get good information out there, but I just want to share some of those resources with you and just acknowledge that it's really bad out there in a lot of ways for folks.
Thank you. Thank you, Caleb. Appreciate that. Appreciate the update. Okay. Next subject we have today, unless there's any more on that, I don't see any hands at the moment. So we'll move on to the R&P. Go ahead, Tony.
Yeah, I'm so sorry. Just real quick, I wanted to follow up.
No worries.
Caleb, for the monthly crime lab data, are you starting to see increased numbers in terms of the amount of like samples or substances being sent to the crime lab? Because I think that's an interesting kind of subpopulation, at least, because that's getting towards at least those individuals that their substance use is being criminalized and they're being involved in some alleged criminal activity that's resulting in that, sample being sent to the crime lab. And I remember us talking about this back when in 2020 and, post State versus Blake, those all kind of, went away, obviously. But are those starting to increase again?
Sure, and I'll throw a link in on that as well. I mean, yes, we saw an overall just dramatic decrease during Blake and COVID. And we continue to see generally an increase, nowhere near where we were before overall. So we're definitely seeing increases. And again, it also makes it hard when we're trying to look for sort of significant unexpected increases, but it's hard when your baseline data are all weird because of Blake being suppressed. But I'll share those as well, where we're noting sort of where we're seeing in the most recent quarter, new cases of synthetic novel fentanyl products, as well as the novel synthetic benzodiazepine. So those numbers are continuing to increase. But to Tony's point, none of the data that I'm mentioning, whether it's drug checking or crime lab data, are what we would consider prevalence data. They don't represent the population. They represent instances of cases where samples were brought in either by a person who was concerned about them or where law enforcement decided to generally arrest somebody and move forward with the prosecution. So they're important data, but they don't stand alone as what we would consider prevalence. They don't represent the whole population. So that subtlety isn't subtle. It matters a lot in terms of the quality of the information we have. And then I'll just note, maybe for the 10,000th time, I don't know what the quality of this state treatment data looks like nowadays. In the olden days, we had great detail in terms of what substances people, what routes of administration, what treatments they were getting. And it's been hard to see those data for the last 8 years or so. And those provide also very important information and insights. And I don't think those are available, but that's a really important measure as well.
Thank you. Okay. Yeah, a lot of good information in the chat. Please check out those links. Thank you for those who put those in. Thanks, Caleb. All right. So R&P report is next. Tony, you want to make any comments about what we're going to hear?
No. Just wanted to thank Tim again for coming and sharing some of those data and a really helpful conversation about overdose and prevalence of substance use and substance use disorder. Real quick before we move to Brianna, I'm getting caught up on the chat. Sorry, a lot's kind of tough to juggle everything. But just noting the comment regarding from Malika about it's past time for safe supply. Just wanted to flag that the safe supply work group that was a recommendation of SURSAC has been convening, and that legislative report is in the final stages of being drafted with the recommendations from the Safe Supply Work Group. And so hopefully when we come back in December, we'll have a link for that, or at least the beginning of January, that should be posted to the HCA website as well as the OFM website for legislative reports. But just, I know there's some in this meeting that have participated or supported that in some way. Obviously, the HCA staff that have supported that as well, but really happy with that work and the resulting legislative report coming out of that. And then just to Caleb's comment regarding SUD prevalence and how we measure that and how we quantify it, what we consider the prevalence of substance use and substance use disorder. You might remember, I think it was back in August or September, Yumiko Aratani came and provided some information about that. I think we followed up through email, but that legislative report should also be posted December 1st, and just really appreciate the SURSAC's input and focus and some of the responses we got to help guide that conversation as well. And so just wanted to kind of flag those two things in response to the chat conversation as well as Caleb's comment. With that, Brianna, I know if you're ready, I think we can start talking about the Recovery Navigator program, the quarterly report. And thanks so much for being here to present that. And I know there's been a lot of work. We continue, and I know you're going to cover this as well, Brianna, but just wanted to flag for SURSAC. We meet bi-weekly as part of a RNP data work group that involves a number of different divisions within the Healthcare Authority, our Clinical Quality Care Transformation team, and our data team there, as well as support from research and data analysis over at Department of Social Health Services. And so we're just continuing to try to improve the way these data are collected, reported, and just really appreciate all the feedback we've received up to date. And just please continue to digest this information and provide ongoing feedback and comments, because it's just going to help us improve in this area as well. So thank you.
All right. Can everyone hear me?
Yes.
Yeah, we can.
All right,
Yes, we can hear you.
Awesome. I'm using an actual microphone, so maybe can help me. So hello and welcome. I am Brianna Peterson. For any newcomers here today, I am the technical plan developer and report administrator for 5476. I also support a lot of the work coming from 5536. Today we'll be covering the Recovery Navigator Program Q2 report. This is based on the April to June 2024 data. We'll also be reviewing some trends that we saw over the last fiscal year, meaning from July 1, 23 to June 24. Sorry, mouse. So during this report, we'll be covering some updates on the report and dashboard, the referral and outreach data, case management data, and the trends for fiscal year 24. So we continue to collaborate with our data group in the clinical quality care and transformation to update and publish the public dashboard. We have an internal work group to review processes and data collection to continue to improve the processes of data collection from the providers, and also our internal processes as well of analyzing the data and potentially creating cleaner data collection for the quarters to come. We currently do not have a date for when this will be published publicly. We're still under review at the moment, but we're hoping to get something out soon. Also, you'll note that I have Q3 and Q4's TBD. I await for the December meeting so that we can discuss what the meetings look like next year's, and then we'll add some dates to this table and provide those to you as well. So let's get into the data. Here we have the referral and outreach data for Q2. As we've previously shared, the data team has established a process to determine the estimated number of unique clients, and we are continuing to improve that accuracy as we meet with our group. According to this data, there were 4,882 encounters stemming from 2,548 estimated unique clients. Keep in mind that some people may require multiple outreach encounters before accepting a referral or transitioning to case management. I would like to draw your attention to our response time, which shows that 72% of referrals received a response within 15 minutes. We believe this reflects the dedication of our field teams and their ability to successfully engage with community partners. I would like to note the law enforcement referrals is currently blank. This is a statistic that we previously have showed in other reports, but we are not currently providing. We encountered what may appear to be an issue in the count of the referrals. there a hand raised? Well,
Yes, there actually is a hand raised here real quick. Sorry, Brianna. Malika, did you have a comment or a question?
Well, I have a question. Can we make this easier to see? Because like it is like super small.
Thanks.
I thought it was just me, but yeah, just a heads up. I was messaging Kelly about it too. And I was like, is this one? So yeah, I'm not sure why though, because like the one that Tim just did was, so I don't know if it's your presentation view, Brianna, but thanks for
might be
calling that
the
out.
screen I'm on, so hang on. I have two, and so I put it on one, and so I'll switch. Let me switch my screens. Whoop, okay. Okay, from
Also, while Brianna's pulling it up, can somebody confirm, is the audio okay in here in this room? I feel like I'm yelling, but I just want to make sure everyone can hear me.
I can hear you, Tony.
Thank you.
Is that better?
Yes.
Okay. But now I can't see hand raise or comments, so just someone shout out.
All right, will do. Thanks, Brianna.
Yeah, we got you. We got you.
Okay. Where am I? Okay. So we've encountered an issue that appears to be with the count of referrals. Instead of like a unique count, we were just doing an entire count, including the amount of encounters as part of the referral number. And so we're trying to configure a way that we can just count the unique referrals so that we can accurately represent how many law enforcement referrals we obtain in a quarter. We don't currently have like an outright solution, but we're working on a couple different variables to see if we can have a firm solution, and we'll continue to provide updates as they come. But this is what is causing the delay for the dashboard. We strive to provide the most accurate information that we can through these reports, and we continue to review and analyze our data for quality improvement. I will note that there is top referral reason, but that is not affected. I did base this information off of the unique clients, so the top referral is based off of the estimated unique clients, so they're 1 for 1. Yeah. And so of the number of referrals from the previous slide, 203 were enrolled in intensive case management, and 364 were enrolled in light case management for this quarter. This leaves about 1,700 individuals in outreach status. Outreach coordinators will continue to build relationships until the individual is actively enrolled and converted into light case management over time. I'm sorry if people hear me repeating myself. I just like to provide some information based on this information for any newcomers. So the difference between light case management and intensive case management. like case management means an individual's interested in basic services like housing. The individual is considered a program participant, while intensive case management means an individual needs, they have several areas of need and might be experiencing homelessness. And another thing to note on here is there is no unknown. This was, yeah. So I can't read that entirely, but just one, I'll get it in just a second. Blake, if you'll give me a moment.
Yeah,
So
no
upon
worries.
review, so I don't know if I'm answering the question, so let me just keep going for a second. Upon reviewing of the data collection workbooks and the data analysis with our team of the quarterly reports, unknown is not an option under race. So though it was previously shown there and that's how it was previously collected on the dashboard, that's not how it was actually supposed to be represented. That was just something that we had previously just kind of dumped everything that we couldn't categorize into something. So now we have the option on here and on the dashboard where it states other, and on the dashboard you'll see it as well. It'll say in parentheses not provided or refuse to answer. And this applies for case management as well. And so it was kind of just an error as we were going through. So Caleb, sorry. Yeah, Caleb's comment, Blake.
Yeah, you answered that, and
Okay.
Malika says is other the new unknown?
Yeah. Yes, no, because it just is two categories that we've put in into one, which is that the individual did not provide, that the individual refused to answer. We're still analyzing it the same way as it was unknown because we want to address being able to collect. Obviously, if someone refused to answer, we're not going to really pry too deep, until we make a better, have better rapport with that individual. But we are trying to come up with ways to address the not provided section, and we're doing that through the data work group that we have. So
thank you. I think we're good.
Yeah.
Thank you. Tony, I saw your hand flash there. Did you want to jump in?
No, it was Brianna answered it. We're all good.
Go ahead, Brianna.
Is there another comment? I just hear dings. Sorry.
So Caleb said, ideally not asked or and refused would be distinguished, to Malika's point, as the interpretation and training impacts are different. Comment there for all of us, I believe.
Yeah, like I said, we're trying
Everett,
to address with the providers as well. So something that we're looking at internally of how many there are, and I'll get into later where we've done some significant updates on us being able to analyze the data a little bit deeper on our end. But I'll get to that later too with some updates that we're doing in the work group.
Thank you. Everett, do you have your hand up?
Well, I was just going to add to Brianna's point, as a member of the TA team for RMP, we're also, the TA team members are doing pretty solid work around the state with helping case managers. The workforce is always evolving and new folks are coming in, and everyone is always training. How do you ask these questions in a way that's culturally sensitive? How do you communicate with people? When we're trying to get so much information out of people in the very beginning and they're not even sure what this program is or why anybody's talking to them. Sometimes we have to follow up a little bit later after enrollment in the program to nail down some of the demographic information. So it's an ongoing effort to try to help instill confidence in case managers across the state to be able to talk about things that they may deem as sensitive. And we always want more complete data, of course, but I think some of this is about when you're on the ground and you're trying to figure out what does somebody need, and they really only have 10 minutes for you because their ride is idling in the parking lot next to you, or their boyfriend's looking on with, slitted eyes or something, so that's a little bit of a contributory factor to the big other category, but it's an active effort to try to get that part of the pie chart reduced.
Thank you.
Thank you, Everett. That's extraordinarily helpful. I know that that's a lot of the information that I get when I'm talking to the providers, but it's really great to hear from you guys in this meeting about, those things, because it's difficult, but we are trying to work on it and get better and better at it.
Okay, Brianna, I think you're good. So please continue on.
So here we have the case management data. We have 2,063 estimated unique clients with 9,500 case management events. That's all the times that we are meeting with these individuals, connecting them to services, providing them all the things that they might need through our program. I will add here again, we had previously in a few last reports, this used to be the contingency management. We have since updated it, and it's reflected in the dashboard itself as incentive-based encounters. We realize that the term does not fully align with the clinical usage of contingency management. While there are a few providers who offer the actual clinical contingency management services, most of the time this is used to represent small tokens that encourage engagement and build rapport. We're still using the term to tie it back to the usage in the workbook until those get updated. But we want to be clear that it does not always represent true contingency management in these reports. And so it's reflected as incentive-based encounters. Sir.
Brianna, did you see the question? Oh, sorry, go ahead.
Yeah, I saw Lisa and I was like, oh, I can only read like 4 words.
The question is, are incentive-based encounters not included in the case management events? So are they being counted as a case management event, or is it not included?
Yes, it's included as a case management event.
Okay, thank you.
Thanks, Malika. I think we're good. Sorry, missed that one.
No, good.
Thanks, Malika.
And so here we have, so here we have the demographic data for the case management. Again, you'll see the other that is reflected there. The case management team oversaw over more than 2,000 clients. The case management team is responsible for providing long-term support and assistance to these clients who are in case management status. This means that their cases require ongoing attention and support, sometimes extending over several months or even years. The level of referral, outreach, and case management provided by Recovery Navigator varies across different regions. However, it's been observed that most of these programs are currently operating at or near capacity, and this issue continues to be noticed by several of the diversion programs across the state. So I want to keep echoing that point. We are hoping to, soon enough, when the dashboard is ready, you guys will see that regional breakdown and be able to look over how the different regions are doing and how they're operating, so that, we can have a lot of meaningful conversations around the regions as well. So hope that comes soon.
Brianna, I had a quick question.
Yeah.
Sorry, can you go back to that last slide?
Yeah.
Look, it feels like the other category, which we had as, unknown previously, but it feels like that for the case management, that's gone down. Is that right?
Yes.
Like, any ideas about how what might attribute to the reduction of the other or previously unknown in that area, with this quarter?
So I have to attribute it to a lot of, the engagement that the case managers are having with individuals. Again, as Everett had spoke about earlier, that it's not really until we get into case management that they're really making those connections with individuals and being able to collect that information. And we are continuing, we have monthly meetings with the BHASOs. I've met with plenty of providers over the last couple months just to, talk to them about, this data collection. And so hopefully all those things all together really attribute to that number going down. And we hope for it to continue to dwindle down and being able to see where those are coming from. I'd actually be kind of curious now thinking about it is how many of those are refused to answer as opposed to not provided. And so
Yeah.
being able to change up how we approach those as well. So.
No, that's really helpful. Thank you.
And so I wanted to provide a little bit of updates to the dashboard, even though it's not ready just yet. There is a couple changes that we've done in the meantime. We've added this little like quick user guide. It's little areas where you can click. There's all these tabs and just little definitions on here. The rest kind of look the same as you've previously seen in other presentations. Referral and outreach, the case management, and the demographic has both. They're just broken down by the color. But we've also been able to update by adding more definitions into the About This report, including, you know, the dates that we have available, because you can search for them, and we'll go over that when we present the dashboard. But yeah, we've added a few more definitions about some of the things that you've seen on the previous pages. And so we'll move on to the fiscal year numbers. Okay. So we had 11,113 estimated unique clients in fiscal year 24. It's quite a bit. And we've had over 26,000 unduplicated encounters. With an average response time of that whole year of 72%. We've also had 7,000 individuals in case management with 51,000 case management events and 17,000 incentive-based encounters. And I did a little bit of math, and so it's about just over 60% converting from case management, from referral and outreach to case management, which I think is pretty good for this year. And then we continue to try and connect with those individuals over the next year. So here is, I wanted to provide a couple of trends so we can kind of see and even discuss the trends for the year and how we've been working with Recovery Navigator program. So here's the total number of referrals and outreach. We were looking at this and we're like, oh, we kind of see the numbers kind of dwindling down. And so is that because more people are getting engaged and they're getting the services, so not that many people are coming in, or, you know, what are we seeing? And so this is a great way for us to look at and have discussions not only with you guys, but with the providers as well, to see, you know, what kind of things that we're seeing on here based on the data and what they're seeing out in the field.
Excuse me, we do have a hand up.
Oh, yes.
Lisa,
I'll
go
go back.
ahead.
Hi, I'm not a member, so just acknowledging that. Thank you for calling on me. Related to that, one possible dynamic that can drive down referrals is referrals being denied because of capacity. So people sort of become, it starts to feel futile to make referrals if they can't be taken on board. And I'm just wondering if you are collecting that, referrals received and denied due to capacity. And if not, I'd suggest that be introduced as an option, because it is a sort of downward spiral that programs can get into, where people give up because they tried and we were unable to take folks on board.
No, that's a great comment, and I'll definitely be tapping on my data team and the providers to have that discussion to see what we can do and we can collect, because that would be a great point to capture. So thank you, Lisa.
Just curious, like while we're on that slide, sorry, Brianna.
No, you're good.
Because I thought you brought up a good point, like just wondering like if anybody, you know, within this meeting in SURSAC or in attendance might have other ideas about what could have been happening in May and June that, you know, maybe it's referrals being denied because of at capacity. I was thinking, some of the new policies that were being enacted around homeless encampments. I don't know if that might impact it. I don't know the timeline for that, but it might be interesting to kind of like do an overlay of like local or regional policies that might have impacted the ability for some of these outreach efforts to get towards or get to individuals in need of them. And so just kind of wanted to open it up because I think that's an interesting point, and it could, kind of just piggybacking off of Lisa's comments, just wondering if anybody else had any ideas or suggestions about what could be, pointing towards that like downward trend we're seeing in this kind of state fiscal year data.
To your point, Tony, sorry, I'm not waiting for somebody to call on my hand. Anyway, but to your point, Tony, I think that it might be interesting to do some analysis, like, as far as like arrest data from across the state, for like at the very least, simple possession, but also, other, things that are targeted by RNP and see what those look like. And also analyze the data to see where the numbers went down and where the numbers stayed the same. You know what I'm saying? So it's like then that, and then looking and then using that to target arrest data, to target, what else was maybe happening in those regions, because then you can kind of narrow it down and see where the hot spots are that there were changes. Does that make sense?
Yeah, that's a great point, Malika. And that'll definitely be something that we'll try to look into with our data group. So I appreciate it. I'm thinking because we also collect, I think it's theft, and there's another one, and I can't think of it right now. But we can also see if we can find those as well. Not only the possession, but I know that there's a couple of referrals here from law enforcement. The RMP collects for theft, and there's trespass. Thank you, Lisa. And see if those increase as well.
And camping, illegal camping would be loitering, all
what was it? Something like interfering with business. I think that's
yeah.
okay.
It gets worse. I mean, the thing is that at the local level, it may be called a bunch of different things, right? So like having to figure out whatever local things were happening, but geographically looking at the places that had the greatest decrease, and then you could see what specifically happened. It would help you focus.
No, that would be great. We'll see what we can come up with internally, and we'll keep you guys updated with that information.
Thank you. Tony, did you have a comment? Sorry.
Oh, no, yeah, just wanted to kind of respond to Malika's comment and, this area around the charge data. We talked about this a couple months ago, and I did send an email to our partners at Research and Data Analysis at Department of Social Health Services. And we're trying to get them to be able to come in November, but I think the agenda was too full and we had to cancel October meeting. But that was something that we had discussed about having a summary of charge data specific to the unlawful possession of controlled substance. And and maybe there will be time in December and we can kind of have them come and present the data analysis that they did. But they did send me a preliminary table, and it definitely does see a dramatic increase in April, May, and June of 2024, up to the thousands of UPCS charges being filed. And so I think that's a really interesting point, that there might be a direct correlation between the reduction in the referral and outreach, because some of these individuals that had previously been referred to RNP are now being arrested, cited, and prosecuted within the criminal court system. And just wondering if John or Chad kind of have anything to comment about that as well, because I think they're, our representatives are working directly within the criminal court system right now. And so it is, and we can also wait and have that conversation on Friday. And I know there's others that reached out that would be interested in kind of participating, maybe in just like a general conversation. But at least for the initial data pool that RDA did, Between July of 2023 and June of 2024, went from 100 UPCS charges to over 1,000.
We did have a question. I'm not sure if Caleb's question got answered. I might have missed it, but how much initiation and ongoing engagement in effective services, example, MOUD, are we able to link to RMP data?
That I am unsure of. Tony, do you have a?
No, I'm
Caleb's
sorry.
question.
Nope. No, all right, hold on. I'm sorry. Somebody teams me and I got distracted. Let me look at the question. Sorry. I might have missed it, but how much initiation, ongoing engagement, and effective services are you able to link to RMP? So right now we're not linking any external data sources to the RMP data. However, we are trying to, that is a topic of conversation with the RMP data work group. And then also just a reminder, the WISIP is currently working on a I guess, an initial evaluation of RNP, but I don't think it's going to include those kind of external data sources, data source linkages like that. But I mean, so to answer your question, right now, we're not looking at that, but we have talked about what that would look like. And I think there's possibility there. So maybe something we can bring back to our work group that we have.
Can I ask another question real quick? So what is counted as an incentive? Are we talking about like if somebody's handed a pair of socks, if they're handed a granola bar, like what is counted as that?
From my understanding, it's like any kind of like monetary, like they paid for a taxi or they got a gift card for food or gas. Paying, I think, one of the providers I've heard, talking about paying for a storage unit or laundry, coins for the laundromat kind of thing. I think Everett might have made a comment too. But it was pretty much anything that had to do with us providing them some kind of like monetary piece.
Well, I don't know. I mean the lead model, part of like having the flexible funds to be able to meet the needs that people are experiencing, that is very different than doing like contingency management. So, and I know you said that earlier when you were like, it doesn't meet the clinical definition. So direct support to clients is being included in that.
Yeah.
Okay, because it seems like it would be better like if we could parse it out, you know what I'm saying? Because that's not an incentive. That's a like, people didn't have access to what they needed, and this was able to help them get what they needed.
No, that's a good point.
Okay.
We are looking at ways to update like an almost like a desk manual for data collection and how to like categorize things and when to like check the box. So that'd be a good thing for us to include on, when to check that box of, incentive based or contingency management. Is that, if it's, direct care services, it's different than some of the other services. So sorry, everything's beeping. I think Sarah also added the definition for incentive-based encounters. But yeah, it would be good to parse out when to utilize that category as well. So I will make note of that. Okay. Is there any other questions, Blake?
I think you're good. Just a comment
Okay.
from Amber about it bothers me that we would categorize direct support as an incentive. But no.
So
You're
here
good.
we have, yep. So here we have the trend for the response time within 15 minutes. 15 minutes is not like it's a goal to respond quickly. Each region, depending on where they are, has different response times, but they've actually been really exceptional to get this number fairly high within 15 minutes, and 15 minutes is the highest, like the quickest that they're supposed to respond to. So really, really great job to the providers for keeping this response time over 60%. Here, I'm sorry, it's really small. I was trying to add as much as I can. But just kind of seeing where those, like the top referrals reasons are coming from. As you can see here, theft and trespass, as we talked about earlier, interfering with business. But we kind of were seeing the trend of, where these referrals are coming from. Majority of the time, it's this general SUD. Again, that's more of a bucket, but we do have a couple where we've broken it down. Law enforcement, arrest aversion, concern for self-harm, possession, and different criminal infractions. And concern for safety, but that homeless and general mental health are kind of just right there after general SUD. These are the top referral reasons. Is there an area where multiple reasons? So we've been having that discussion internally. So typically we'd like for it to just be like the one area where we're collecting that information, but there was at one point an option for people to multi-select in the workbook. So there is areas where they've been doubled. The problem is that it's hard to count those, and so they've typically not been counted in those top referral reasons. It's because we were trying to look for those unique referrals as opposed to ones that have been doubled up, because it's hard to tell which one came first or next or last. Or so we've tried to do away with the multi-select so that they're only selecting the top like most reasonable option for what that referral came from. But yeah, general STD is just a bucket, so I apologize. But here's the top referral to services. So basic needs is the top trending. Then comes housing, public benefits, which I thought was really great because it looks like we are trying to connect people to public benefits and getting them, enrolled in Medicaid and Medicare, and getting them benefits. And so that was one of the things, is like, do they have a Provide One ID? Like, they might not, but it looks like here that we are trying to connect them to those services and being able to connect them to us in various routes. What is it, Blake? I'm sorry, I keep on seeing it in the corner.
Sorry about that, Brianna. Nikki also had a question. Thought you were going to pause there in the chat. Is there a tracking process for when there's a lack of access related to these referrals? For example, if an SUD referral is made, but there are no providers available, etc., or there is a significant wait time for services? Basically wondering if there's a tracking mechanism to outcome of the referral.
Not at the moment. We have a lot of hopes that, as we move to more like data integration platforms, that we'll be able to track them. But as of right now, we are not really tracking those individuals from start to end. I mean, it'd be great, right? To see where they're getting connected, if they're coming back again for similar services or other services, like kind of thing. But we're not currently tracking at this time.
Thank you. And Malika had her hand up. Go for it, Malika.
I just am concerned about like clumping it all together as public benefits. It feels like we should be saying something around, like what is like health insurance. Like that's a very basic thing, because when you say something like a blanket comment about public benefits, for folks that don't understand what's happening, it sounds like, these people are getting all this stuff, but when in actuality, healthcare is just like, or health, not even healthcare, excuse me, health insurance is the only thing that folks that are in really desperate circumstances might be just initially getting connected to. And to Caleb's point about then how often, and then we can track how often does that lead to them engaging in care. And, like if they get connected with some like disability or SS, like some other thing, then like we could be tracking that. But I just feel like this is a recipe for disaster for folks that would be like, look at them, they're taking all these public benefits, when in actuality, the only thing they have isn't much more than what they maybe ever had before, which is health insurance. And we're not getting at the like desperate circumstances that people are experiencing and that they're coming out of, so that we can really tell the story of this work. And so from a data collection standpoint, I feel like there needs to be more nuance.
Yeah. No, that's a great comment. And yeah, I can see where that can, be taken by, someone from the public. There's so many stories about taking money from public benefits, but I mean, really, I believe that majority of the time it is just trying to get that health insurance and getting them connected so that they can get care, right? But it would be good to be able to break that down so that we can kind of see where they're getting those public benefits. So yeah, that would be a good thing, that we can break down that category into a few.
And then we can start looking at like what we call in HIV, like the cascade of care, right? Like, so when this many people get connected with, Medicaid, then they get connected to care, then they we start to see a decrease in their behaviors because then they also get housing. Like we can really tell a story about like what's impacting people's lives and helping to stabilize them.
Yeah, no, that's awesome. We are looking at making edits to the workbook as we move into a better data collection program. So that would be awesome for us to include when we're making those updates, is to break that down. So thank you, Malika. I appreciate it.
And I'm not sure if we covered Caleb's question. I know it's a Recovery Navigator program, but what about the referrals? And then it jumped on me there. What about the referrals to healthcare, health engagement hubs? Can that be tracked? So
Yeah,
not sure if we answered that or
yeah,
not.
I know that's a newer program, but yeah, most definitely we can add that to the drop down as well.
Thank you.
Thank you. And here's the last trend that I captured. Again, if you guys want anything else for next year, in December, I know we're gonna have some like polls going on, so please just let me know what you guys would like to see. You can also message me directly if you guys want to see different kinds of trends. I tried to just pick a couple of the top things that people might want to see, but if you guys want to see something different based on the data that we collect, please let me know. I'm more than happy to get that data ready for you guys. So this is the case management engagement, and we have the total number, and then those engaged in light case management and intensive case management. I'm gonna go here. So the RNP data work group, yay! Something fairly new for the last just few months that we've been working on. This group includes participation from Department of Social Health Services, Research and Data Analysis, RDA, as well as the Clinical Quality Care Transformation and their data analysts. We are, as I was talking about previously, is trying to kind of distinguish between the not provide and refuse to answer, is that there's been some great improvements to the error identifying tool. Matt Montgomery, he's not here, but super big kudos to him for helping me get this off the ground and updated, where now we can really go through the entire workbooks from all the providers and really identify where some pitfalls might be, some blanks might be, some, kind of common errors that we see, so that we can adjust and we can update to get cleaner data. So he's provided me an updated tool that's been amazing to really help me and help the providers. So really happy about that. We've also begun the discussion of process for the RNP data collection. This change will improve data validation. It is a data validation tool, it does collect data, but it's more of a data validation tool, and it'll hopefully help reduce the data entry mistakes just based on human error, and resulting in more accurate, cleaner data. And fix several of the inconsistent data collection issues that we've seen. They say this is about a 6-month project, but that's being very that's being very optimistic. It might take a little bit longer than that, but that is our projected timeline. And we hope to have something in 2025. We're going to be including research, interviews with providers, examining workflows, developing new workflows, building, new forms, new workbooks, testing the system, providing training, pamphlets, and a support line for the new system, and then the go live. This is an incredible undertaking, and we now have a dedicated project manager and business analyst that is overseeing the project from start to finish. Some of the next steps that we have going on, we are continuing to discuss the collection of the demographic data, especially during the referral and outreach, on how to better collect that data, so that we can start minimizing those not provided or refused to answer, along with, in case management as well. As I talked about earlier, for the law enforcement referrals, we are looking at, ways to address the number of unique referrals versus the total count of referrals, to try to give you guys a better number of, especially what those law enforcement referrals look like. And that is me. Does anybody have any additional comments or questions?
Caleb, go ahead.
Yeah, I have a question. This is super helpful. Thank you, Brianna, for presenting all of this. I'm trying to figure out, to Malika's point, if we think about people receiving services, I'm trying to understand sort of this idea of cascade of care, how a person moves through our systems. It seems like these RNP data are still somewhat segmented and isolated, and there's no way to sort of, I guess it would be for RDA to partner with WISIP on this, but how to understand, I think, all the questions we're asking, which is how are people moving across all these systems of care? I recognize that's a super hard thing to do from a data perspective. I know King County has some opportunities to do that with something they call the Integrated Data Hub, where you can link all these different data systems. I'm wondering whether there's a goal or a mandate from leadership, either at HCA in particular, I suppose, and maybe governor's office, although I know they have a little short timer. So I'm curious though, like, is there any plan to sort of like actually try to integrate everything so we can actually understand the cascade of care and where we're seeing people drop off? Because we know transitions of care are really, really tough for folks, and we're trying to build in some staffing and processes to address that. So I'm just curious if there's some big picture goal of someday we hope to link all these data and actually understand how people move across, or if there's just no mandate or funding to do something like that. Thanks.
Yeah, no, I mean, that's the dream, right? Is to be able to do that. And so what I will say is that the programs that we're using, PDAMs, EdFX, whatever it is, it does connect to provider one. And so that's, the first thing is that initially we're going to connect to that provider one, and, we're going to be able to, connect that information together. Now, obviously people don't have provider one numbers. It might be a little bit more difficult, but we are trying to connect that information to provider one. It will feed and be verified with provider one as well. Now, we do have, in adult SUD and DBHR, we are moving a lot of the programs to that type of data collection. So, I mean, there's nothing really saying that you couldn't eventually try to connect those. Obviously, there'll be a lot of work, but we are trying to integrate those into just one big system. Tony, I don't know if you want to add something from, executive leadership side.
Yeah, no, I was trying to find the link to HCA's data strategy for 21 to 25, and I know it continues to evolve, but I believe there is a plan as part of PDAMs, which I'm forgetting what the acronym stands for right now, but there is an idea about either through an enterprise data warehouse or some sort of HCA held database where all of these data that are collected, whether through the Homeless Outreach Stabilization Transition Program, whether it's Provider One encounter data for Medicaid, whether it's the Recovery Navigator Program data, the end goal is to ensure that all of those are located in one place, whether it's the Behavioral Health Data System database or an enterprise data warehouse. And so I'm thinking what may be helpful is to have somebody that's closer and more knowledgeable about that work maybe come back and kind of share with SURSAC and the attendees what some of like the future goals are around data collection as well as like data storage when it comes to the number of programs that the healthcare authority is administering. And so I think we can probably find the right person to do that. And then that might help provide kind of like that higher level overview of how we are envisioning the data flow that comes through the healthcare authority and how it can be combined and connected on the back end. Because I mean, you're 100% right, Caleb. Like right now, this is just an isolated data set, but like we're really going to get a better sense of impact and coordination and collaboration if we're able to connect it with other data sets for those sort of kind of outcomes and trends.
All right, thank you. Lisa, you had your hand up? Lisa, can you hear me? Maybe on mute.
No, I was trying to save the data strategy. Sorry. I was just flagging that I think it would be wise to add a layer of integration, and I don't mean like in a mechanical way, but just additive, having an additive approach, blending the RNP outcomes with AJA outcomes with LEAD outcomes, and just acknowledging that the largest LEAD program in the state is in Seattle, and it hasn't been funded to this point by the state, so you're never seeing those data. But in terms of, sort of the overall impact, that is 1,400 people and an enormous number of substantive encounters. And I just think it behooves all of us to, at some point, notice that the bucket is all of those very, very similar endeavors. And it ups the overall weight of this work, I think, to tell that collective story. So yes, there are independent funding streams, independent grant programs. We're reporting on them independently, but I think it would be smart to also put them side by side and notice the, the actual cumulative impact of these very, very aligned efforts.
Thank you, Lisa. I see some nodding heads. People have got that in the room. Okay, thank you. Anything else for Brianna or on the subject of the RNP report?
So I have a question related to, so it said that it was TBD about when this stuff was going to be publicly available. Is that why we didn't get it ahead of time? Like the report to look at it?
Yeah, we saw that issue really like last minute as we identified that issue, and it was just kind of a scramble to get all that information. But I will send out this this PowerPoint with the notes, so you guys can have this. And yeah, so hopefully you guys will get an update here soon. And we'll get some dates on the books for the next report.
Okay, thank you.
Yeah. Well, thank you guys. I appreciate you all so much. This has been really amazing, and I appreciate all your comments. I'm going to take all this information back and work with our data team and try to get some of this stuff going. Thank you.
Thank you. Yeah, a lot of great. Tony, anything else to add before we move to RNP highlight?
No, just noting that we're almost right on time with the agenda schedule, which rarely happens when I'm facilitating a meeting. So just kudos to that. as well as thanks again, Brianna, for helping share that information. And I agree with Lisa. It was a great conversation, and so we'll take a lot of that feedback and we'll circle back around.
All right, thank you, Kelly. I think you're up.
All right. Morning, everybody. So we have R&P highlight. So I just wanted to make sure everybody knows that the people speaking. So we're gonna have the regional people speak first, and then introduce their person. We're gonna have people with lived experience speaking today. Just make sure you know that the people speaking, there are R&P participants, so they won't have program or operational knowledge about the R&P stuff. So I just want to make sure to notate that. And so I'm going to introduce my first person, Katie Pearson.
Good morning, everyone. So my name's Katie Pearson. I'm the R&P administrator for the North Central region with Carillon Behavioral Health. And I'm so excited to pass to Josh Gitt and Crystal Gunn from Okanagan.
Good morning, everybody. My name is Crystal Gunn. I'm the Senior Program Manager for the Recovery Navigator Program here at Okanagan County and also oversight for Grant County. Today, I'd like to introduce one of our participants, Joshua Gitt, and he will be speaking today on some of his lived experience. Yep, you're good.
How y'all doing? I'm Joshua Gitt. I was ground zero for y'all in these programs approximately 33 months ago. 33 months ago, I entered I entered Okanagan County Jail. I've been arrested over 30 times. I'm 47 years old. Been arrested over 30 times in my life. I started drugs and alcohol when I was about 16 years old, marijuana and alcohol. When I was about 25, I got into some harder drugs, cocaine, and then after that, methamphetamine. That progressed into just in and out of jail, in and out of jail, in and out of jail. And, about 2006, my uncle and my aunt stepped in and they offered me treatment. And I sent over a power of attorney to my uncle, and he was able to get me enrolled in the treatment services. Now, keep in mind, I had to sign over power of attorney to do that at that point because there was no Recovery Navigator programs. Also keep in mind that I had tried, AA in the jails, I'd say 2000 on up to now. And now, like Okanagan County Jail, they don't even allow churches or NA or AA or any kind of recovery. The only thing they got posted on the wall in there is the bail bonds. It's point, no point. You got no hope. They take away all your hope, and you're buried in problems. Your addiction is taking you down a road that most people, get suicidal over. And I had been there too. So to get back to track, I went to treatment for the first time in 2006. I got kicked out, couldn't follow the rules, and went back the next year. So it was 2008 when I went back. It was late 2006 when I first went. I think it was 07 when I got kicked out because it rolled over into the next year. 08 I went back, so that was my second time. And I had a decent run for about a year, but again, no services, no mentors outside of the meeting halls. There was no voucher programs. There was no navigator programs. There was no real hope other than what I could muster up and what I could find in the meeting halls. So I kind of roller coastered, managed to stay out of jail for a little bit, longer periods of time after going to treatment. So treatment did work some, helped me pump the brakes. And of course I tried using again, based on being quote unquote smarter, because I learned some shit in recovery, right? And that didn't pan out. So in 2022, I was sitting on 3 strikes. My daughter was 3, and Okanagan County was they were not trying to let me get into any kind of drug court or DOSA program. And I didn't even know about Recovery Navigator program yet to this point, in 2022, right? 2022. So I'm in the unit in Okanagan County, fighting my cases, thinking they're going to strike me out. And I see this kid on this gadget called the Home Wave. The Home Wave is a face-to-face. Your people can put $20 on, and it costs you X amount of credits to have a face-to-face conversation. And that's how they're doing visits these days in the county jails. They're no longer having people come down into the lobby and pick up a phone and talk to you through the glass. That's all shut down. Now they're doing it through automated, internet style visitation. A, it's a moneymaker for them, and B, it's a lot more convenient for them. I see this kid on the Home Wave, and he's talking to this guy, and this guy's talking all kinds of recovery. And I'm like, well, who's that guy? So he says, this is Greg Bland from Recovery Navigators. I said, what's Recovery Navigators? He said, it's an outreach in the community that, he's like, I don't know. He can explain it better. You want me to have him talk to you? And I'm like, yeah. So somewhere along the line, during the next couple conversations the kid has, of course, I'm like a parrot on his shoulder, trying not to ear hustle this conversation, but at the same time, I'm eager as ever for something different, something that will help this guy change his life. And I'm here to tell you that it's hard to hold back tears right now. Just reflecting on how far I've come because of this recovery navigator named Greg Bland. His story and my story are like parallel. And, we went hard on the paint and had no brakes. And nothing could stop us in active addiction. And then when we got to some type of recovery that was jail induced, there was no hope. It was, okay, I'm going to quit. And when I get out, this is what I'm going to do. That hope was always short-lived, until I met a navigator, someone who was able to plant seeds in my mind that had a handle on this thing, some years in recovery, had been through the dope game, had been hung out to dry in prison, institutions and jails, been through the same rigmarole, tried to do it on his own. Is now a recovery navigator, and the door, it was like a door opened up, and his hand reached down and said, there is a better way, and I can help walk you through it. And I'm not just some guy pushing keys on a keyboard. Like, I'm an addict. And, you know, been in the dope game and been down the road that you've been down. And I see you want to change, and I want to help. So I'm like, well, okay, what can you do for me? He's like, well, I want to hear your story. So I tell him my story. He's like, all right. And he's like, so here we are. This is what I can do for you. I could put $20 on your home wave. I could put $20 on your phone. I can talk to you anytime you want, anytime that I'm available, day or night. I'll answer the phone for you. What do you want to do? I said, I want to get in the drug court. The dude went in there and he went to bat for me. So, like I said, they didn't want me in drug court. I'm a hardened criminal, known felon, assaults, DVs, dope on my record, and no hope. He tells me, don't worry about it. I'm going to get you in there. So I don't know what's going on. All I know is Stu gave me his word. His story sounds good, and everybody sounds good when you're in jail. You know, it all sounds good. Well, he got in touch with all my people, had them write letters. People I could and couldn't talk to because of my track record with them. You know, the trust was gone, the bridges were burned. He put them back on the map, so to speak. Now, mind you, that didn't mean that I started talking to people again. That just means that he was vouching for me and letting people know that if he could do it, I could do it. And things are different now. He's going to navigate me, and he's going to, like, forever be there for me. To this day, the guy and I talk. We're friends, and you know, I could probably call on him for gas money, and he'd be there for me. You know, do I need to today? No. I haven't had a license since 1996. I got my license. A year's worth of insurance. I just moved out of the Oxford house. I've been there almost 2 years. I got my own place. I'm moving into my own place for the first time since 2005. This is hard. So let me back up a little bit. So they offered me 33 months and 1 strike. If anybody knows what doing time on a strike is, you're getting a 10th off. That's every 10 days, you get 1 day credit. So I would have got 3 months credit in 33 months. I would have done 30 months flat. I would have got out. My daughter would have been almost 6 years old. Matter of fact, I'd still been in. Vicious cycle, recidivism, jails, institutions, and death. That's what they tell us in the program recovery. And it's true. Had I not met up with Greg through happenstance, I would not be here. I'm sure of it, because I was ready to give up trying to get in drug court. And they told me if I wanted drug court, they were going to give me 120 months over my head that I would have to sign to a post-conviction. That means if I graduate, my time is served, the 120 months goes away, so to speak. But whatever felonies I signed to, 10 of them, would still be on my record. So that's 10 plus the 6 that I already had. And after 10, you're off the scales. So every point after 10 doesn't even matter, because you go into the biggest bracket. You're 1 more point, you're catching 10 years. So I signed to 120 months. I talked to Greg for probably $60 worth of FaceTime, wrapping my head around the seriousness and the level of severity and dedication it would take to commit to this. And so my commitment level was there, but my fear factor was huge. It's still huge. So I'm in phase 4 of drug court at this point. I am a month and a half into phase 4. It's a 6-month phase. And you know, there is a guy or two, and there out of like 25 of us, that he has 0 sanctions. That guy, I gotta wonder. You know, they say that you shouldn't be able to go through drug court without a sanction or 2. You know, we couldn't follow the rules to get in jail. How are we gonna follow the rules in jail, type thing? And you know, then take that to the streets. You can't change anything unless you change every single thing in your life. You know, I have been working on changing every single thing in my life, but I have a team of people that I have built and that have been there for me. Crystal Gunn is my newest team member, which she came through Greg Bland in the Okanagan Recovery Navigator program. And so through Greg, I've met Crystal. I've been invited to speaker events. This is the 2nd time I've spoke on my story. And, you know, talks about in recovery, in the rooms of recovery, we hear these things called the promises. And it tells us, the program recovery tells us that we will receive at some point, we will begin receiving the promises of recovery. Real friendships, the ability to mentor other people, sponsor other people, a team of people that are clean and sober and like-minded. You'll find that promise being granted. getting your license back, being able to pay your bills, being able to be a productive member of society. These are the promises. I am well within the boundaries of the promises. I'm receiving them. They're being granted to me.
Hey, Josh. Hey,
Yeah,
Josh, I don't want
yeah.
to cut you off because your story is so powerful, but there is another panelist. And so if you can just kind of wrap it up, that would be amazing. And thank you so much for sharing. I just appreciate your story so much.
For sure. Yeah. So anyway, I can't thank the Recovery Navigator program enough. I want to become a coach. That is my next short-term goal and long-term goal. My life is now goal-oriented, and I have a team of people that are here for me and that I can call on at any given time. Appreciate you guys, and it's just one day at a time and pushing a hard line with a team of counselors. And I appreciate you guys, and you're just a major part of the team. You guys are the team. Keep that in mind, and God bless.
Thank you so much, Josh. You want to say something? Just want to notate in the chat for you, Josh, if you get a chance, and Crystal, if you could show them the chat and let them know all the hearts and everybody saying his speech was so powerful, and we're super happy just to hear from him. Thank you so much, Josh. We appreciate you. I do have one other person, one other panelist, and it'll be Cameron from Greater Columbia.
Hey, good morning. This is Cameron Fordmeyer with Greater Columbia Behavioral Health, but I will kick this over to Melissa Dinner, who's actually the program manager for Merit, and introduce our guest speaker. Melissa. Melissa, I see you're on, but you're on mute.
Yeah, seeing Melissa's comment in the chat, Melissa, maybe log out of Teams and log back in sometimes. That helps. There's nothing that we don't have any kind of barriers, so it may just be something where you need to log out and log back in. And Everett's got some good advice as well.
Yvonne, maybe you could do the introduction then.
Can you see us?
We can, and we can hear you.
Okay, so my name is Yvonne. I'm a recovery navigator at Merit Resource Services. Melissa Dinner is my supervisor, and I had the privilege of introducing Diana Keith.
Hi, I'm Diana. I kept trying to figure out what to say here and how to say it. Anyways, when I first started this, I got out of prison, and after spending so long in there, it was really hard because everything changed when I got out. I did a really long time. So I went right back into doing drugs to be able to cope with everything. And then I got in trouble again and was looking at going back to prison. At that time, I realized that this was not the life that I wanted, but trying to get
sober, I had more than just me being a convicted felon that was a barrier for me. A bigger barrier for me was the fact that I was transgender. I had treatment facilities that I couldn't get into because they wanted to put me in with men. I mean, there was just multiple problems. And then my pretrial counselor gave me Yvonne's phone number here. And when I went in there and seen her for the first time, there's a lot of things went, like I felt like nobody was going to understand my story. And the cool part is she did understand it, and she helped me. And before that, I was extremely suicidal. I mean, and when I got to the point in the opt-in program, when they asked if I was suicidal, and I said yes, I mean, there was just so many barriers for me to get sober. Getting in housing, I couldn't get into housing because of the transgender thing. I mean, there was just a lot of problems, and it felt really hopeless. At one point in time, I did try to commit suicide, and when I did, and I was getting ready to leave the hospital, there was nobody there but my recovery navigator. So I was, instead of feeling completely alone, I felt like there was somebody there for me. So it was really hard. But the one thing that the recovery navigator helped me realize is that I am important. It's not what I am or where I came from that defines me. It's who I am and where I'm heading to. And I worked really hard to get there. Every time there was an obstacle in my way, instead of me doing what I normally do, is just give up and say, this is just what's going to happen. They helped me see past that to get over the hurdle, either around it or over it, that there is other avenues that can be taken. And they did. They got me in, they helped get me into a treatment facility that did accept me, into a female's one. They helped me when it came time for my name change. They were supportive of that. I mean, it was so much. The recovery navigator meant so much to me, and the hope that they helped me get in my own life and where I knew I wanted to be, that I wanted to be one. And that's why I get to sit here today now as a recovery navigator, because I want to share the fact that there is hope out there. I mean, I can't explain what this program has done to me. It's beyond words. It was life-saving for me. It helped me realize that my life is worth something. And I mean, I can't explain it any more than that my life was worth it. And it's because of this woman and Melissa and everybody else that's in this program that helped me realize that. And the cool thing is, like I said, now I get to sit down and I get to help people. I'm just in a place where I never, ever thought I was ever going to be. I thought I was going to be back in prison, or I was going to die from self-harm, you know what I mean? So, like I said, this program, it means everything to me. And I appreciate everybody in it so much. I don't know what else to say.
Okay. I think we had a comment or a question from Deontay. Do you want to say something?
Yes.
Go ahead.
Yes. Thank you so much for sharing your story. I'm loving. Thank y'all so much, SURSAC, for bringing lived experience in the room and folks that are out there doing the work. My question is like, what advice would you give for us that are out there doing the work to be more inclusive towards LGBTQIA community members? Vocal has also stated this before about the hardships that community members that are coming out of incarceration, how hard it is to find them housing. What words of encouragement would you give to folks that are out here kind of leading these efforts?
That there is hope, and that just because somebody says no doesn't mean that somebody's not going to say yes. There is, I mean, it's going to be hard, and the fact of the matter is recovery is not easy.
Yes.
So, I mean, it's just giving them hope and the possibility, and just letting them know that that's okay, that this happened, that it doesn't mean that it's not going to happen, and just get them to go on to the next one and the next one and the next one. Eventually somebody's going to say yes.
Okay.
The good thing about that is when you have somebody believe in you. She used to tell me that she believed in me until I believed in myself. And that's the good thing, is believing in them to help them move on is going to help them believe in themselves and being able to overcome these obstacles.
Thank you so much.
Tony, we are at time. Do you have any comments to take us out?
No, I just, echoing everything that's been stated in the Teams chat, and just really appreciate the vulnerability and bringing these stories, and just such amazing work happening. There's really nothing more I can say than that. I mean, I know we didn't get through the agenda, but we can address that in the notes that Kelly sends out. And then anything that wasn't addressed today, we'll pick up in December. But just really appreciate people sharing their time and their stories and their experiences with Recovery Navigator program. And I think a lot to take away from this, and just really, great meeting. And just thanks again to Josh and others that shared their stories today.
Thank you so much, everybody. Have a good afternoon.
Thank you.
Have a good day, everybody.
Take care.
Thank you.